and talk about a different topic, which is how diabetes affects the skeleton. And I'm going to focus a lot on a recent study that we did, which involved bone material properties in people with type 2 diabetes. So in terms of my disclosures, Active Life Scientific provided the microindentation instrument and probes that I'll provide, and Diagnostics Technologies provided the AGE reader, but neither of them had any control over the outcome or the content. Okay, so of course we're all exceedingly familiar with the complications of diabetes that can include blindness and renal failure and neuropathic issues. But what's recently come to be appreciated is that people who have diabetes also have an increased risk of fractures. And you could even argue that this might have been subtly hinted to in the seminal work of Elliot Jocelyn, when he even noted that fractures can occur in accompaniment with high urinary glucose measurements. And I think it's been well known for a time that fractures are increased in people who have type 1 diabetes. It's been shown that they have an increased fracture risk of about 6 to 7-fold at the hip. But what's also now known is that people who have type 2 diabetes also have an increased fracture risk. So it's not as high as if you have type 1 diabetes, but in these two meta-analyses, which together encompassed over 1 million people, it showed that the age-adjusted risk for hip fracture was increased about 40% in type 2 diabetes. And once you also took into account BMI and bone density, the risk was even higher, about 70% increased hip fracture risk in type 2 diabetes patients. So again, it's not in the same order of magnitude as the type 1 diabetes risk, but when you think about how many people have type 2 diabetes, it's certainly something to take seriously. In the Women's Health Initiative, and this was a study with over 90,000 postmenopausal women who were followed for at least 7 years, they showed that it wasn't only an increased risk of hip fracture, but it was almost at any site, really, except for the forearm, that women with type 2 diabetes were more likely to have an increased fracture risk. And you could say to me, well, obviously people with diabetes are going to be more likely to fall. You know, they're not seeing as well. They don't have as good neurologic function. They might even get hypoglycemic from insulin. So maybe this is all just a function of them being more vulnerable to falling. But even after they adjusted for falls in this study and in other comparable large epidemiologic studies, the increased fracture risk still persisted, suggesting that it's not something to do only with falls, that it's something above and beyond the increased fall risk. And this again is a large study where they showed that there was a more than 66% increased risk of fracture in patients with diabetes. But even more importantly, in this study, what they showed was that if you were a diabetic person who had a fracture, you were much more likely to have complications in the hospital as opposed to a non-diabetic person who had a fracture. So a diabetic person as a complication was more likely to have deep wound infection, to be septic, or even to die. So I think you could say if you're taking care of a diabetes patient, that this worrying about their bones probably doesn't seem to take as much priority, and that's appropriate, as worrying about their risk of MI or having a limb amputated or renal failure. So it doesn't certainly rank up there with the most life-threatening complications, but I think the risk is clearly increased, and if it does happen, they're clearly worse off in terms of the consequences that can develop. So I think it's easy to understand really why someone with type 1 diabetes would have a great vulnerability to fracturing. Can you guys think of any reasons why that might be, mechanistically?
They grow more poorly.
Right. So, yeah. So first, they have lower bone mineral density. So we already know that bone density correlates with fracture risk. But just like you were alluding to, they can have compromised peak bone mass because a lot of the time type 1 diabetes is first going to begin at the age where children are accruing their main bone content. And we also know that insulin and IGF-1 have anabolic bone effects. So if you're missing normal levels of these in type 1 diabetes, that can adversely affect how bone is acquired and maintained. And I think even if you give insulin exogenously, It's not the same as endogenous normal insulin exposure because there's some exposure of insulin through the portal vein, and that mediates how the liver makes IGF-1 and IGF-BP3, which is important for bone growth as well. So even if you're giving a type 1 diabetic insulin, it's not going to be the same as them having their own natural insulin. So I think there's a lot of reasons why someone with type 1 diabetes, you're going to worry about their bones. I think it kind of makes sense. But it doesn't really make sense why you would worry about it in someone with type 2 diabetes. So first of all, does anyone know what the bone density is like in someone who has type 2 diabetes? Just going along with the argument I'm making, their bone density is really good. So it's normal or even increased, and that's even after you control for their increased BMI. So this is just showing, what you guys probably know are cutoffs for bone density criteria of osteopenia and osteoporosis. But this was a very big study, the study of osteoporotic fractures, and it showed that even after controlling for BMI, someone who had diabetes had about a 5% better bone density almost at any site, at the radius, at the heel. And so that doesn't really make sense why someone who has a higher bone density would be more likely to fracture. And this study made a similar point, which showed that somebody who has diabetes is going to act as someone who is about a half a standard deviation lower than someone who doesn't have diabetes. In other words, if you do a bone density on a woman who has diabetes and her T-score is minus 2.0, you really need to think of her fracture risk as being more like a T-score of minus 2.6. So you have to shift it over in your mind, okay? So their T-scores, their bone density is really underestimating what their fracture risk is. And it's also been shown similarly with fracs, that if you do fracs on them, that it's also underestimating what their fracture risk is. So what that's suggesting to us is that there's something aside from the bone density that's compromising the bone in diabetes patients, and that's not being captured by the bone density. So that's the first piece that doesn't make sense. Why would a group of patients who have increased bone density be more likely to fracture? But the other piece of evidence that doesn't make sense is that their bone turnover is very low. And the classic paradigm that we think about with postmenopausal women being at increased risk for fracture is what kind of bone turnover do they have? High, right. So usually the higher your bone turnover is, the more likely you're going to have an increased risk for fracture. But multiple lines of evidence show that in diabetic patients, they actually have low bone turnover, which usually we think of as a protective thing. That's why we give postmenopausal osteoporotic people bisphosphonates. We want to lower their bone turnover. But multiple studies have shown that their PTH, which regulates bone turnover, is low even when they have a compromised EGFR. Markers of bone formation and markers of bone resorption are low, and these seem to be related to their increased fracture risk. So when we looked at this even further in a small group of patients, kind of similar to the story that I showed you with hypoparathyroidism, when we looked at control women and women with type 2 diabetes, again, you could see there was very little tetracycline uptake. So again, this other model of there being a low bone turnover state. So two pieces of evidence don't really fit, which is that people with type 2 diabetes are more likely to fracture, but yet their bone density is fine and their bone turnover is not high. So kind of like the two cardinal things that we usually think about increasing fracture risk in regular postmenopausal women don't seem to be applicable. So it's really a mystery. In other words, like what's wrong with their bones? Why are they fracturing if these things don't seem to be impaired? So one idea that's been suggested is that there's just more holes in their cortical bone. And this is a very dramatic picture. So this is a cross-section of a tibia in a normal person. And you could see this is the idea of cortical porosity that I was mentioning before, that if you just look, it looks as though the cortical envelope is like moth-eaten, So, and this is an abnormality that the DEXA would totally not pick up. It's not sensitive enough to see these microscopic pores in the cortical bone. So this finding has been reported in a few cases, but it seems that this isn't the whole story. First of all, it hasn't been found in all studies. Second of all, it only seems to be present in women who've already fractured, so it doesn't seem to be a discriminating characteristic of women who just have type 2 diabetes. And third of all, it seems that the difference in the cortical pores isn't enough to explain the weakened bone strength and the propensity to fracture. So we think that this is probably playing a role, but it's not the whole reason why you would worry about a fracture in a diabetic person. And again, I'm coming back to this idea that I alluded to beforehand, which is that bone isn't just the structure and mineral, but it also is composed of the organic collagen material component. So it's almost saying like you could build a building with the exact same architectural layout, but you could use cement or you could use wood. So it's like the structure could be the same, but the material you're using could be altered. And that could alter the bone strength in a way that you totally would not detect on the bone density. So does that concept make sense? We and others think that this is a lot of what's going on with the type 2 diabetics, which is that their structure is normal, but that there's something off with the material of what's actually making up the bone structure. So the first idea that this came about was from other investigators at the Mayo Clinic who looked at this. So it's very hard to test the material of bone. Like, how could you do that? You know, like, really the only way is to do a bone biopsy and to look at the material under a microscope. Sorry. But what these investigators did at the Mayo Clinic was use a novel technique, which is called microindentation, which we also went on to use, and I'll show you our data. But it actually involves using a tiny probe that indents the surface of the bone. So you actually see just how deep the probe sinks, and the idea is that the worse the material of the bone, what do you think happens? The probe will sink deeper because it's not able to resist it as much. And so that means that the more the probe goes into the bone, the worse the material strength of the bone is. And they did some preliminary work that showed that in women who had type 2 diabetes, that they had worse bone matrix properties. In other words, the probe sank deeper, even though these women had total normal bone densities. So this was in support of the idea that there was nothing wrong with their structure, but there was something off with the material that the bone density completely could not pick up. So the question we asked was, okay, fine, so there's something wrong with their bone material, but why would their bone material be off? What could be causing them to have a worse bone material? And the idea that we came up with is that they might have accumulation of advanced glycation end products. Have you guys heard of these? This is, it's basically a chemical reaction that happens when a protein is exposed to a sugar for a long amount of time. And it forms this compound that first is irreversible, called a Schiff base, but then it becomes irreversible and becomes an advanced glycation end product. And it's been well described in other tissues and people who have diabetes. They accumulate these AGEs, as they're known. They accumulate in the kidney, they accumulate in the skin, and they, in collagen, make these bad types of cross-links, which actually weaken the quality of the collagen. And everybody gets AGEs just with normal life, but people who have diabetes, because there's so much more sugar floating around and proteins are exposed to it, are much more likely to get abnormal accumulation of these advanced glycation end products wherever they have collagen in their body. And what's important is that they fluoresce. So if you were to actually do a bone biopsy on a diabetic animal, it's been shown, and measure how much the sample fluoresces, it would be higher because there's more of these advanced glycation end products. But nobody knows in humans if that's the case also. So it has been shown in animals that they have more of these advanced glycation end products, but we really don't know in people if this is the case. And you would say, oh, so why not do a blood test? You can measure, the most common one is called pentosodine, and you could see if your patient has higher pentosodine, that means they have more of these. But the assays are all very bad, and none of them are able to detect a difference in pentosodine. They're just all not validated. So really the only way to kind of see if your patient has more glycation in their bone would be, hypothetically, to go ahead and do a bone biopsy. But we had this idea that the same way that these AGEs accumulate in skin maybe correlates with bone. And there are, in fact, studies that show that the level of AGEs in skin, which you can easily measure, does correlate well with the levels in bone without doing a bone biopsy. So you could just use the skin as a surrogate to see, are the AGEs higher, and does this relate to what's going on with bone material strength? So we chose to use this measurement called skin autofluorescence because the AGEs fluoresce. So the same way they would fluoresce in a bone biopsy, they fluoresce if they accumulate in your skin. So if you were to look at the skin of a diabetic woman and measure their fluorescence, the worse her diabetes is, the more likely her skin is to fluoresce. And that's a way of measuring the increased advanced glycation end products in the skin, which indirectly correlates with the increased advanced glycation end products in the bone. Does that make sense? So that was our idea, to use this way of seeing, is it the increased advanced glycation end products that's compromising the bone material and making it weaker in the diabetic women. So we hypothesized that bone material properties would be worse in women with type 2 diabetes because of this increased advanced glycation end product. So we had two aims that we wanted to do. First was to indeed confirm, using that microindentation tool, that it would sink deeper in the diabetic women as compared to the controls. So to kind of repeat the study that had already showed that, and then to see, did it sink more in the women who had more advanced glycation end products? In other words, to show that the mechanism for the material of the bone being worse and letting the probe sink was because there was more accumulation of the advanced glycation end products. So we studied 35 postmenopausal women. 16 had diabetes and 19 were matched controls who did not. They had to be postmenopausal for at least 3 years. They had to have good vitamin D levels because a lot of times diabetic patients have low vitamin D levels, so we didn't want that to be a confounding cause that maybe their bone material was just worse because of low vitamin D levels. And we had a whole list of exclusion criteria. They couldn't have anything else going on that could potentially be a confounder that was hurting their bones. What medicines do you think we excluded? If you had to take a guess. Exactly, because thiazolidinediones have been shown to impair bone formation, so nobody could be on a TZD. Also now the SGLT2 inhibitors have been shown to have adverse bone effects. Nobody was on that either. And we didn't want them to be on any bone active agents either, because that could also throw the measurements off. Now we also did have to exclude African Americans, and that's because our measure of skin fluorescence didn't work in people who had very dark skin. So that was a limitation of our study, as I'll show you. So this is what the procedure actually involves, the microindentation. What you do is you first measure from the patient's knee to their ankle, like how many centimeters it is, and then you find the halfway point, because you want it to be exactly in the mid shaft of the tibia. So you find the halfway point that's like right on the front of the leg, and the reason is because you could just feel the tibia. There's almost no soft tissue there. And we mark that spot, and then we injected it with a little bit of lidocaine, and that really is the most painful or uncomfortable part of the procedure, putting the lidocaine in. And then we use this probe known as the osteoprobe, and the actual needle itself is about the same width as a human hair, so it's very tiny. And you hold the probe perpendicular to the tibia and indent it, and it's a fixed amount of force. So that's very important, because it's not like you're pushing it in harder with some or others, but it releases exactly 40 newtons of force. And then you get a measurement that's calculated from the machine. It's hooked up to a laptop, which is called the Bone Material Strength Index, and essentially measures how far the probe sinks into the bone. And we would do at least 10 measurements on each person. We would go in a little circle and then get an output that showed us what the measurement was. So that kind of explains it. And we had a good coefficient of variation. This is just showing what happens actually with the tool, that you kind of press it and then it releases this trigger mechanism that gives a fixed amount of force. And the patients tolerated it very well, I have to say. The lidocaine was the only painful part. This is me and our senior fellow, Jessica First, who really led the study. So this is kind of what it looks like. Although we weren't actually doing it. You have to make a sterile setup to do it. So to measure the skin autofluorescence, we use this tool. So the patients would rest their arm on this little box. The room had to be totally dark because what happens is in the box there's a little light source, and it emits a light that excites any fluorescence in the skin. And then the tool is able to measure the wavelengths that are being emitted by the skin. And if there's more fluorescence, then it gives a higher number. This is what the output looks like. So this is just an example. One of our diabetic patients whose A1C was 8.7. So you could see this is where her measurement came out. The measurement was 2.7. So you could see it's higher than the mean. It gives you what the mean should be for that age. So this was an elevated skin autofluorescence, and the numbers correlated very tightly with the hemoglobin A1C, kind of as you would expect. So this is just to show you that we weren't able to do it. It worked in patients who had skin color 1 to 4, and for patients who had skin color 5 to 6, the tool would do it and make a correction if that would work, or if the skin was too dark to be able to detect any fluorescence, the tool would tell us that the measurement could not happen. And we also did the conventional structural measures. We did DEXA, and we did whole body composition because we thought maybe body fat could be related to some defects in material. And we did the high-resolution peripheral quantitative compute tomography, which I told you is kind of like a virtual bone biopsy. We did have one sort of issue in the middle, which was that we swapped out our old tool, HRPQCT, for a better second-generation one that even gave more detailed pictures. So that could have been a problem to switch from one tool to the other, but we had another study going on that showed that you could correlate measurements from one to the other. So that was okay. So this was our study population. You could see they were all basically the same age, in their mid-60s. The diabetics had diabetes for about 14 years, and they didn't differ with other issues that you would worry about in terms of menopause, in terms of BMI, in terms of history of smoking, using SSRIs or PPIs. And also their body fat didn't differ either when we did the body composition. So that was another good way they were matched. There were some occurrences where patients had history of nephropathy or retinopathy. They were all on metformin. So if anything, metformin's actually been shown to have a good skeletal effect. So, I don't think that it would have, made our results, that it could have adversely affected the bone material of our patients. And their hemoglobin A1Cs on average were 8.3%. So kind of by study entry criteria, they were higher with higher glucoses. And their vitamin D levels, although they trended to be worse in the diabetics, they weren't significantly worse. And then, as kind of has been shown in other studies, their bone turnover markers were low. So both bone formation and bone resorption were low, as has been previously reported. So the first thing we found was that the bone material strength index, or this measure of the probe sinking into the tibial bone, actually was worse in the diabetic women. So this confirmed this previous report showing that the probe was more likely to sink deeper, and this was suggestive of their compromised bone material strength in the diabetic patients. So it sank about 9% deeper in the diabetic women as compared to the controls. This isn't from our study, but it's just to show you a deep atomic force microscopy scan where they look in tremendous detail at the bone, and you could just see how the indent, this was done on a cadaver, in a diabetic cadaver compared to a non-diabetic cadaver, was wider and deeper. So again, consistent with the bone material being worse. Yeah?
What level of change in the indentation correlates with increased risk of fracture?
I think, it's a research tool and there are limited data using it. But I think that about a 5% change has been shown, in cross-sectional studies to be predictive of an increased risk in fracture. The studies are by Diaz-Perez. It's a hyphenated last name if you wanted to look it up. So we also adjusted for anything else that could be hurting the bone. If they had nephropathy, because renal dysfunction could hurt the bone. If they had neuropathy, even retinopathy, it didn't change the results. And because the vitamin D tended to be lower, not significantly, we also adjusted for that, and still the bone material strength index was worse. So this was really the heart oh no, not yet this, but this showed that the longer you had had diabetes, the worse your bone material strength. So there was a dose relationship. So if you'd had diabetes for more years, that meant your bone material strength was on a downward slope. And this was interesting because it wasn't shown in the previous study that had been done, but really does argue for the diabetes exposure really being harmful to the material of the bone. So as you would have expected, the skin autofluorescence, or this surrogate marker of advanced glycation end products, was higher in the diabetics. They had more fluorescence in their skin because they had more accumulation of advanced glycation end products in their skin. So this was really the heart of our study, which was that in the diabetics, having a greater amount of skin fluorescence, which measures the advanced glycation end products, was associated with having worse bone material strength. So this meant that, yes, their bone material strength is worse, and the more advanced glycation end products you have that have built up in you, the worse your bone material strength is. So this is suggesting a mechanism for why their bone material strength might be worse, because the collagen in the bone is becoming encrusted with glucose, and these bad collagen crosslinks are building up and making the bone more vulnerable in a way that utterly would not be detected on bone density. And in controls, this relationship did not exist at all. So there was no relationship between advanced glycation end products measured in the skin and between how deep the probe sank, or their bone material strength index, in the controls. It only existed in the diabetics. And when we looked at the relationship between hemoglobin A1C and the bone material strength, or the probe, it was very similar to what we had seen with the skin autofluorescence measurement. In other words, the higher your A1C was, the worse your bone material strength index was. And this relationship existed, again, only in the diabetics and not in the controls. When we looked at DEXA, as other studies have shown, their bone density was fine in the diabetics, or even better than normal. So they had this worse bone material strength despite their DEXAs being totally fine. They were actually even higher than controls at the femoral neck and at the total hip. So just doing a DEXA on a diabetic patient would not really tell you if she's at increased risk for fracture, because it wouldn't tell you if there's something off with her material in her bone. And similarly, when we did the HRP-QCT, so this very highly detailed structural assessment, at the radius we saw that if anything it was better in the diabetics in terms of trabecular bone and in terms of the stiffness that you could measure from these calculations. And at the tibia there were some trends for it to be better, but it wasn't significantly different. So this is to make, again, the point that these very detailed structural parameters aren't showing anything. We did not see that cortical porosity that I showed you the picture of the moth-eaten bone. And we don't really understand why that is. So it might be that we just had too few patients, and if had we done it in more people, we would have also seen those holes in the cortical bone. A lot of the studies that have reported it have been in women who had fractured, and we weren't selecting for a fracture population, so that might be why. It also might be that you need to scan higher up in the arm and the leg to be able to see it, because those are more cortical enriched sites. It also might be that the pores are really tiny, and that we thought maybe using the newer machine, I told you we switched in the middle of the study to this more detailed machine. We didn't see it just using the newer machine, but that was even a smaller subgroup. So I don't know if we did a bigger study just using the new, more sensitive machine. Maybe we would, in fact, pick up these cortical holes, but we didn't in this study. So in terms of bone turnover, I already showed you this in the table, that bone formation and bone resorption were lower in the diabetics as compared to controls. So that's been previously reported. But what we saw was interesting was that the higher the advanced glycation end products was, so the more accumulation, the lower the bone formation was in the diabetic women. And this is interesting because there's animal and in vitro data to suggest that accumulation of more of these advanced glycation end products cripples the osteoblasts. So this kind of would be in line with that idea that the more these advanced glycation end products are building up, the worse the bone formation is. So maybe this is part of an explanation for why bone turnover is low in diabetics. And we didn't see it in the controls. Okay, so these data are exciting, and they're actually in press for JCNM, but there are certain important limitations that I need to tell you. The first criticism is that people have said, like, okay, so you're sticking the probe in and it sinks more. Do we know that this is really the same thing as seeing that bone mechanical properties are worse on a bone biopsy? You know, can you accurately translate from one to the other? Also, you're only testing the outer part of the tibial bone. Does this really extrapolate to what's going on at the hip and the spine? The answer to that criticism is that there's been a lot of bone calibration testing comparing bone biopsy samples and comparing doing this technique in the peripheral tibial bone that seem to correlate. And even more importantly, it seems that it's giving a robust clinical assessment of something that's wrong in the bone that we're not able to otherwise pick up at all in the diabetic women. So even if we're not 100% sure what it's measuring, it seems that it might have some clinical utility. It's a little bit like, are you guys familiar with TBS, trabecular bone score? It's a measurement that's extrapolated off of the spine bone density. Nobody's really sure what it is exactly, but it gives a lot of valuable clinical information. So I think here, even though there's been some uncertainty about what exactly it's measuring, it still seems to be useful. The other weakness in our study is that as we did 10 indentations in each woman's leg, you can see if any are off and you can remove it yourself. So you could say, oh, maybe you're biased because you're just removing the ones that are off, but we used the protocol that the manufacturer told us, which was to remove any that were more than 2 standard deviations outside the mean of the measures. For example, the first measurement was always off. So, you know, we just like learned automatically to remove that one. Another limitation is that we had to exclude African Americans because we couldn't accurately measure their skin pigmentation, their skin autofluorescence, and that's really important because diabetes is so present, of course, in African Americans, so that does limit the applicability. We had to switch HRP-QCT machines in the middle. Yeah, we didn't look at all if they had different types of type 2 diabetes. In terms of the safety, it sounds a lot more invasive than it is. I just did it yesterday. It's really easy to do, and we use the analogy to patients that it's like using an acupuncture needle, which I think is a fair comparison. So I think people think it's very frightening sounding, which I get, you know, to put a needle in someone's bone, but it's really like this tap, and we haven't had any complications from it. And the indentations, again, are like the size of a human hair. We do them in a circle. Some people have said you should do them in a line, but we were worried that could increase the risk of initiating a stress fracture. So we just, once you put the needle in, you indent and then just drag it a tiny bit, indent again, and kind of do 10 like that in a circle. And they were all at least 2 millimeters apart. So to summarize what this shows, I think first of all, it shows that we really need to have the skeleton on our radar as a complication that's an end organ that's involved in type 2 diabetes. And that this might be a tool to assess bone material in diabetes, and is very useful because if you see a patient in the clinic who has diabetes and her bone density is normal, that really tells you 0 about her risk of having a fracture. So this might be a way of being able to risk stratify who's at risk. And moreover, this might be a mechanism with showing that increased advanced glycation end products might be what's causing it. And this perhaps can set the stage for therapeutic interventions. For example, it's known that giving vitamin B6 can stabilize or even reverse accumulation of advanced glycation end products. So who knows, maybe if that could be a therapeutic intervention that would reduce accumulation of advanced glycation end products and improve bone material strength in these patients. So what we kind of put it together at the end is that if you have type 2 diabetes, you're going to have increase these advanced glycation end products, and that's just because your collagen is exposed to so much extra glucose that's floating around. If you have type 2 diabetes, there's also a decrease in bone turnover. And then these exacerbate each other in a vicious cycle, because if you have low bone turnover and more of the same collagen laying around, it's going to have more of a chance to accumulate these advanced glycation end products. And similarly, when you have advanced glycation end products, they also inhibit osteoblast activity. So they're kind of exacerbating each other in a vicious cycle. And we think that these advanced glycation end products are going to profoundly inhibit bone material strength. At the same time, there's also the evidence that diabetes is causing an increase in these cortical pores. And we think this can also separately inhibit the bone material strength. And that together, these mechanisms are going to lead to increased fracture risk. So this is certainly a very preliminary hypothesis, but I think this is something to go forward on to understand more about why people with diabetes are more vulnerable to having fractures. So that's the end. And again, our fellow Jessica First, she screened 171 people to get these people in our study and really did all of the work for it. So I'm happy to take any questions about it.